Hey, what's up, guys? Jay, just to talk through another quick case study. This is a 27-year-old, trying to fit the screen here, 27-year-old female who presents with a 12-month history of lower kind of lumbar pain. Only time it was really an issue was first thing in the morning. First thing in the morning was when it was particularly sore. And then it diminished, that level of pain diminished throughout the day, and she was pretty much fine, bar some irritation with sitting. Improves in movement. She bought a new mattress, no difference. She is also in past medical history 6 weeks pregnant, so she's in that first trimester. And the quality of pain was something like a sort of aching type pain. No pins and needles, no neuro symptoms subjectively whatsoever, and her goal is basically get rid of the pain that she gets first thing in the morning. So that takes us on to the objective, and her lumbar active range of motion was unremarkable and not limited, so no pain provocation and no obvious kind of movement restrictions. So we got her into sitting, and so when she was sitting up more in an extended position it was worse. When she started to relax down to more of a kind of flexed posture it was better. Then take into account the pregnancy, we had to think about the positions we were assessing her in. So we went into quadruped and to try and look at some more kind of I guess kind of just some more flexion extension, pelvic control. Was she able to dissociate between kind of lumbar pelvic type movements, that kind of thing, just the regions of her spine. We found as expected that her kind of anterior pelvic tilt was quite pain provocative, so 3 to 4 out of 10, and I noticed that she started to, the majority of that motion was coming through her kind of upper lumbar, that kind of thoracolumbar junction, and reversing that relieved it, so the posterior pelvic tilt felt much better. We then did some rotation in supine, so almost like a kind of Pilates hip twist, and we found that going to the left, which should be fine, going to the right was quite pain provocative, 4 out of 10, with only about 30 degrees. So I was like, okay, well maybe what part of the spine are we sort of dealing with here? So I varied the degrees of flexion, so as I flexed her up more through her hips and rotated, the pain was more severe and it took less range to provoke it, and the opposite was true as well. So conversely, the more extended I position her hips, she increases the range and reduces the pain. So what do we think is going on there theoretically? Well, the more you kind of flex segments, the more you kind of take out the available motion of those segments. So you will look at the kind of the ones above. So it's the same with when you do like a cervical flexion rotation test, and you're really looking at like a C1, C2 in that, just like the test you do for, say, headaches. So you're locking out all of the lower segments and just looking at really that upper cervical, in this case upper lumbar. So it fits with where she was hinging when she was doing the pelvic tilt. I also palpated, did a bit of a palm, and it was sore on her kind of L1, really, on her central PA. Sore when she kind of extends. And so we're thinking that she's going to create some torsion through that upper lumbar area and resulting in her symptoms. So the next thing is I thought, is that area rotating because other areas aren't? The ones that are staying quiet but aren't painful. And main sense of rotation we're thinking of upstream, downstream, the thoracic spine. So we did put in a quadruped, sort of SFMA type quadruped thoracic rotation, and it was fine, 45 degrees, left equals right. Her hip rotation was absolutely fine, so no issues there. So to finish up with, we kind of created a best fit sleeping position for her. Given that she's pregnant, we're really looking at just a sideline position. So we put her in left side line, so if she does rotate, it'll be going to the left and not to the right. We try to make sure that she's going to be positioned a bit of posterior pelvic tilt, and we walk her through that. That posterior pelvic tilt can be facilitated by a bit of hip flexion. So we brought her hips up slightly, pillow between the knees to prevent and reduce the likelihood of kind of going into rotation. So, just a lot of lumbar cells in neutral. And the only other thing, I suppose, was, just enough of a degree of flexion so that she got the relief, but not putting so much on unnecessarily so. And so we're going to try her out with that, see how she finds, reassess her pain first thing morning, see how that's going, and then we'll let you know how it goes.